So we're going to be performing the endotracheal intubation. So the indications for this procedure is you want to, provide and secure means of maintaining a patent airway for the patient. If the patient has lost ability to maintain a patent airway in their own, or if they're at risk for losing the ability to ventilate adequately. Endotracheal intubation, you may have to bypass anatomical obstructions to clear the airway and provide means of suction to clear it as well, and removal of foreign bodies. Positive pressure ventilation with the airbag mask, and possible need for creation of airways surgically.
Contraindications include laryngeal disruption itself, including trauma where the airway is not patent, and airway compromise must never be tolerated. Therefore, possible cricothyroidotomy may be necessary.
Alright, so let's talk about complications. Intubation can cause some anatomical complications. If you do a nasal intubation, you can traumatize the turbinates, the adenoids, or you could dissect the retropharyngeal tissue. An oral intubation, you can cause damage to the lips, the teeth, the oral cavity, the epiglottis, or the vocal cords. There's a slight risk for cervical spine and ocular injuries. You could cause bleeding, and then there also is late complications such as vocal cord paralysis and potential risk of aspiration. Then there's some physiological complications. If intubation is not done rapidly or quickly, you can be causing hypoxia, hypercarbia, cardiac dysrhythmias, hypo or hypertension, some ICP, vomiting, aspirations. And then there could also be some late physiological complications such as pain, sore throat, speech problems, dysphagia, pneumonia, or possibly sinusitis.
Okay, so if you know you're going to intubate a patient in advance, you would want to prepare them mentally and also obtain some good information and past medical history about the patient. So continue to find all the information about the past medical history, inquire about previous intubation, if they had any previous difficulties during that procedure, and look at all the old anesthesia records and see if there are any problems or any complications that arise afterwards as well.
Okay, let's go over the intubation equipment. The first thing we've got here is the BVM, stands for bag valve mask. This is what you'll use to pre-oxygenate the patient and maintain respirations and ventilations while you get your equipment ready. And we will also be attaching the ET tube to this. You need to have a suction catheter in place. This is for suctioning any aspirate or vomit that the patient may have, and to make sure that airway is clear for an easier intubation. This right here is called end-tidal CO2 detector. It changes gold in the presence of carbon monoxide. You put this on the tube after the intubation. If it changes gold, that means you have the tube in the lungs, and it's a confirmation device for a positive endotracheal intubation. Moving on to the laryngoscope, you can have multiple different size handles. This is a large one, this is a small one. There's really no difference depending on user preference. Typically there's two types of blades. We have a Mac blade, it has curved. This blade is designed to go in the vallicula and lift the epiglottis. And this end of it right here slides into the vallicula, and then you lift it up. Over here we've got the Miller blade. The Miller blade is straight, it doesn't have the curve that the Mac does. This is designed to just lift the entire epiglottis. You don't have to worry about getting into the vallicula space with this. In addition to this, you will need a 10 cc syringe and your ET tube with the stylet pre-inserted. This right here is to give you some good rigidity so the tube doesn't flex and not go into the airway, and the syringe is to inflate the cuff at the end. And then once the cuff is inflated, it can't back out of the vocal cords.
Prior to intubation, you want to provide a good seal with the bag valve mask with the EC technique, and you continuously pump, providing oxygen to the airways there while the intubation is being prepared. Giving one breath every 5 seconds.
Okay, so while the patient is being ventilated, you need to assemble your equipment. The first thing you want to do is fill your syringe up with 10 to 12 cc's of air and attach it to the ET tube. You want to insert your stylet, but you want to make sure the stylet does not go past the edge of the tube because this could cause damage to the trachea and or the vocal cords. You don't want that to happen. Go ahead and put a little bend into it. This will help navigate around the tongue and through the vocal cords. And then you want to check your laryngoscope handle and blade. And what you're looking for is you're looking for light, tight, and bright. A lot of these blades have a little bulb on the end of it that rotates. You want to make sure that that is screwed down tightly, and that way it doesn't fall off into the oral cavity. So we've got light, tight, and bright. This equipment is good. The next thing you want to do is obtain your confirmation device. We're using CO2 colorimetric indicator. Keep this in the package for as long as possible because you don't want a false positive. So, okay, it looks like we're ready. Our equipment is set, and we can move on to intubating the patient. All right, Aaron, I am going to intubate. Go ahead and remove the bag valve mask. All right, going in, lifting the epiglottis. Coming in from the side. I see the tube going through the cords. Okay, go ahead and remove the stylet. Inflating the cuff. Hook up the colorimetric device. Go ahead and start ventilating. Okay. You can see on the mannequin we are in the lungs. How we would tell on a real person is this would turn gold because it responds to CO2. We would do a 5-point auscultation. We would first listen over the belly to see if we hear any bubbling. That means the tube went into the esophagus. Then we don't want to hear that. And then we want to listen to 4 separate spots in both lungs so we hear good, clear breath sounds. In addition to this, we could remove the colorimetric device and hook the patient up to end-tidal CO2 monitoring, where we would look for an end-tidal CO2 wave of 35 to 45 millimeters of mercury, and that would say that we have a very solid endotracheal intubation, and that is successful. And then we'd also follow that up with a chest X-ray.
Following endotracheal intubation, be sure to reinforce the tube with tape or a commercial device. Also obtain a chest X-ray and auscultate over the lung spaces and stomach. If rapid sequence intubation is required, IV medication should be administered. IV sedatives should come before IV paralytics. You do not want your patient to be paralyzed prior to being sedated. Other indications for endotracheal intubation include using the LMA. So you have your LMA, you have your empty syringe, and you have lubricant. First, you will check the patency of the LMA by inserting air. Now that we know that it fills correctly, we will lube the LMA. We'll extend the patient's head, flex their chin, and do a blind insert with my tube bearing. There you go. And we will inflate, and we will start ventilation. And then to confirm that you're in the correct area, you will auscultate over the lung space to make sure you hear air, and you will also auscultate over the stomach to make sure you don't hear bubbling.